everyone, my name is Melina and this is
Jordan.
And we're the board certified
BAes. And today at Calaba, I had the pleasure of being on a panel with our guest, Nissa here, that I'll allow to introduce herself. She put together an amazing panel and it went so well, so we had to have her on.
Well, I appreciate the invite. Dr. Nissa Intarachote Van Etten. I'm a BCBA, and I was very excited to be invited to the podcast.
Yay, so excited to have you here. So we'll kind of jump right in and get started.
Okay.
So you spent 20 years in this field, and you chose to dedicate your doctoral research to compassionate care. For most people, that might seem a little unusual for an academic focus. So why did you think it was worth doing this for your dissertation?
Well, yeah, that was a great question. Why is it important? I think soft skills are important. It's one of those pieces of the work that we do that it's embedded in the science, but not in a very overt manner.
Mm-hmm.
I guess I can go back to how I was trained, and I became board certified, or not board certified. I got into the field long before there were requirements by funding sources. So there wasn't insurance reform. I was working and paid by parents directly. So they hired me into their homes to work with their children, and the supervisors weren't even behavior analysts. They could be master's level psychologists, special educators, and really that training really brought into my perspective the perspective of the parent. And everything was in home, everything was socially significant to the family, which required a compassionate lens and the understanding of soft skills. Like the parents had to like me to pay me out of their own pocket and to allow me to do the very hard work that was working with their children. So as the field has evolved, Bridget Taylor and colleagues wrote a paper, I think in 2019, on soft skills and compassionate care. When I read that paper, it resonated with me. It was one of those, this is what we do. There's no name for it. We have to be, emotionally responsive. We have to ask open-ended questions. We have to have a countenance, a face that orients to the family, that shows, I understand your pain and your grief. And they spelled it out in that paper in a way where it made sense to continue that work.
Amazing. I love that. That's huge. And I know this sounds really ignorant, but I think I've heard a few times this weekend like the hard skills versus the soft skills. When you talk about those soft skills are necessary, can you kind of explain a little bit what you mean by that?
Yeah. That was when I was going through the dissertation process. That is what my chair really pushed on me, that we've got technical skills that we're trained in. We have our task list, we have our ethics code, we have all the requirements that the board puts in front of us. Now that we have the ethics code that talks about compassion, dignity, and respect, but compassion isn't clearly defined.
Right.
So in the research, in the history, you can look to allied health professions. So a lot of nurses and doctors have training in soft skills. They define them, and they're very clear. It is asking open-ended questions, demonstrating empathy, understanding and being sympathetic. It is making eye contact. It is nodding at moments that are appropriate. It's having the body awareness to listen and show that you are not checking your phone, reading your emails, not really attending. All of those skills are laid out in other fields in a way that we can say, okay, I can take that and I can actually apply it to our own science. In our training, the technical skills include defining all of the jargon, right? That we've got a lot of jargon in our science.
True.
And when we think about what master's students are coming out with, it's understanding schedules of reinforcement. What is a MAND? What is a TACT? How do I apply an intervention? Sometimes we miss those soft skills. We don't even have names for it.
Right.
It's not in the Cooper text, and unfortunately, that's what we learn.
Yeah.
But everyone, when they're studying for the exam, it's test prep, some different test prep solutions, and then Cooper.
Right.
We need those, but when we go into home, sometimes that has to go right out the window, and we have to just be able to sit with that family.
Yeah, and that kind of brings to the next question, which is, what does it look like in home? Is this something that should only be locked to BCBAs, or is this something that should go from all levels through? And what's your kind of take on that?
I think everyone needs soft skills training. I think RBTs, they're more often. Again, in the model that I remember being trained in 20 years ago, I was the RBT and the BCBA and the person changing the behavior in the moment. With our tiered model now, the technician is in home more often, so they should have heavy emphasis on soft skills.
I love that. Do you feel that compassionate care is like a skill that can be taught, or is it something that people just naturally have? Like,
yeah, I think it can be taught.
Okay, what does your research say about that?
My dissertation was taking, we defined what a novice behavior analyst was. The term wasn't great, so early career professional.
Okay.
Someone new, less than 5 years experience, and I put out a poll for participants in the study, and they had to meet specific criteria. Less than 5 years, they had to also take something called the Jefferson Scale of Empathy.
Okay.
And that Jefferson Scale of Empathy would evaluate your score of empathetic skill sets. There are about 20 questions, and 10 are written in a way that's very straightforward, and are you empathetic? The others are written in this negation type way, where if you answered a specific way, it would almost give you a negative score. My participants, I had 4, 3 of which demonstrated kind of in that range that they were empathetic. They were already coming into a helping profession with compassion. I had 1 participant who was well below what a helping profession indicates. And the literature, Hojat and colleagues have done a number of literature and evaluations on this in dental health work and nurses and teachers. And what they found was most people going into human health services also were already empathetic. And there are some that truly maybe excelled at technical skills, so the definitions, the text, but they didn't have the personal connection. So, what the literature says is that we can teach it. Nursing literature says we can teach it. There are a number of papers out there. My dissertation found that 1 participant who was below the score of empathy improved their score by 10 points after asynchronous courses, modeling, BST, and feedback.
That's great. I think so. It already exists in other fields, not necessarily ours yet. No, which is good because that would have taken time. But to a field that is predominantly women, right? Like the men are typically a minority, and then men of color are even further of a minority, right? Men are typically trained from young ages to be the strong, there's the stereotype that we're like fathers have instilled to build, or mothers even have said, no, you got to be stronger than this and build in. So the point the reason why I'm bringing that up really is you said it can be taught. Now, when it comes to warning signs that's missing or that's not there, do you recognize, is there a difference between men and women in that, or is it harder to teach for a male than a female even?
Yeah, you know what? I honestly couldn't answer that question with literature.
That's okay.
I can say anecdotally, and even just from my own personal life experience, as a behavior analyst, my family falls into that trap. My husband does tell our sons, don't cry. You need, tough it out, stop crying. And of course, being a behavior analyst and reading literature, I'm like, you can't say that. He can be emotional. We're gonna let him. And then he'll say stuff like, no, we're not gonna allow that. And then that's the dynamic that is shifted in that they're naturally emotional, right? My sons are young boys. They're not being influenced, at least at an early age, where that is a natural tendency. And then we shape them to become tough and to hide it and to almost repress those feelings. Do I think that there's a difference in that would be a great thing to look at in the literature? I'm sure Hojat has that in his publications on men versus women. I do think that it can be taught, but I also think that there is, if you've attended any talk on compassionate care, there's this notion that it could be taught or we can mask it. I know we talked about masking in our panel, but there's a level where sometimes we do have to mask, especially when it comes to rapport building and emotional connection. If truly we have clinicians we've hired that just don't have that empathy in their behavior. I mean, I've had to tell staff, look, you look like you don't care, just fake it.
Yeah.
Show a way to show that family that you care. Change your body. Look them in the eye. I know that's hard for you. So I think that we can do that for a positive.
I think that's true. For me, I always felt like I wasn't an empathetic person. That's just not something that I naturally had. It had to be something that trained. I actively had to work on.
Trained as in he married me and I.
We are opposites in that one.
Yeah.
There's a lot of let it fall where it falls, in the way I was raised and things like that. But that's my perspective, right? The multicultural household that I grew up in and where I grew up instilled all of that, and so some days I'm like, am I masking this or do I feel this? Which one is it? Which way is it? And
that's a human question though. There are times when I'm entering midlife. Now I'm admitting that on a podcast. Where there are times when I have to sit with emotions that I'm feeling. And I think most of my life it was, I'm not feeling that. I've got so much to do, I can't deal with it. Now it's like, sit back, reflect on that emotion, and either move on or do something about it. But most of us, especially in our busy phase, we just brush it off and we keep going.
Yep.
That is true. And to your point too, of what you mentioned about, fake it, like show the body. Like those are all things that we can objectively identify and define on those things that are needed to display that emotion that can, relax a family or like release some tension if we're able to show those things. So I do think it's a really important skill to be able to at least describe.
Absolutely. And I think, going back to the Taylor paper, and then Roaring colleagues wrote a paper on soft skills that really should resonate with our field, and that parents are, in the Taylor paper, parents indicated they wanted a behavior analyst that asked about their other children. They wanted a behavior analyst that cared about their family, not just the goals, the data. Yes, those are the technical components. We have to have them. But do you care? Because the parent's not going to want you in their home if you don't care.
Right.
Right. You'd rather have someone else.
Yeah. No, I hear that. Okay, so is it possible to implement compassionate care but still implement ABA principles like punishment, extinction?
Yeah.
Thoughts on that?
Absolutely. I know that there were talks here at Calaba on this topic. I know that there are a number of our colleagues that are working on that, on defining it, measuring it, bringing in assent, dignity, right, respect of our clients. I think that there's a compassionate way to layer in all of our science. I also think that you have to truly be a scientist practitioner, in that you have to understand why you're applying the science versus protocol driven. If you have a protocol and you are following a protocol, especially as a technician, but you don't have compassion, it's going to be hard to go with, okay, I'm following the protocol, which we should do as technicians, but I need to also be compassionate, because right now it looks like my client is struggling. It looks like they're very stressed. It looks like I should reach out to my supervisor and check in because maybe I'm not doing it right or something is happening.
Right.
And I'm following the protocol, but now I don't know if I'm being compassionate.
Yeah.
So I think there's a space for both.
I love that. Thank you.
Yeah. So switching up just slightly, you are at a fairly big company in terms of like the amount that you have, and you're in leadership, right? You do the training, right? The director of training, right? So where do you find, so you've had the pleasure of training tons, dozens, hundreds of people, I'm sure, at this point.
I think if they watch the CEUs, yes, I'm hopeful. I'm hopeful that you watch.
Hopefully they should. So where, like in it's broadly speaking, but like where in the field do you see the biggest gap in compassionate care?
Ooh, wasn't prepared. I didn't study for this one. I think it's interpersonally with colleagues, which is really not a stretch. I think that we're getting to a space in the field where there are so many of us. And I think one of the themes that I like to make sure that I impact on is opening the door for other people. Speaking names for individuals who don't have a seat at the table. I think that compassionate care there's publications now, there's conferences on it, there's CEUs, there's trainings. We're starting to say, okay, we can overtly demonstrate that skill even if it's not within us. We can bring in those really great technical clinicians and teach them compassion, or teach them to show it. We need to be compassionate amongst ourselves. We need to really leverage our science at these conferences, right? And we need to be more open to allowing everyone a seat at the table. I'm ready for the field to really be more inclusive of everybody.
Yeah.
Which is a stretch because that's not where I was going. But, I think that we are just so, there's, I don't want to call it a myth, but there is a stigma that BCBAs have egos. And I would love for that to just fall out.
I would say that that's true. I mean, I feel like, a while ago we did another episode and we were talking about the business side of how like clinicians own businesses gatekeep everything that they've done. Supply of BCBAs is never going to meet the demand. Like at the way the rates that are coming out, like we're not going to meet. So like, what's the point of gatekeeping? Like this system didn't work for us. Like just share, like, these are the things that I failed at, and like help the next generation of BCBAs coming through that are going to be I can't even speak right now. Clinician-led businesses, right? And so, yeah, to that very point, I think, yeah, you're right. I also would say, like, you hit it with the compassionate care towards colleagues and coworkers. You know, the whole back in my day, we got like this, just toughen up. Like, no, yeah, like everyone's experience is everyone's experience, and we can't justify because our experience was different that we can discredit somebody else's experience.
I think there's enough room, like you're saying, in the field for us all to be successful.
Yeah.
Absolutely.
Enough room.
At the table.
And if not, just like we did on the panel,
we added another one.
We make room.
Go watch the panel, by the way. It was really good.
Yeah. Okay, so, you know, as clinicians, the field of ABA in general, we are oftentimes in the most vulnerable spaces with these families, whether it be in the homes directly. You witness everything.
Oh, yeah.
You know, beyond just, you know, a season of a fresh diagnosis.
Mm-hmm.
There can be marriage issues. There can be, you know, you're helping a child and now their siblings getting diagnosed. Like, there's just so many things that we walk through with these families just because we're present in those moments. How do you, you know, train someone to honor this space, especially with the lens of compassionate care?
I always lean on the cultural responsiveness, first of all. I think that's a big component of understanding that cultures are very different.
Mm-hmm.
Parenting styles are different, marriage styles, communication in marriage.
Mm-hmm.
Some families are comfortable fighting in front of their technicians.
Yes.
And some families are very private.
Mm-hmm.
They leave the technician to do the work. They don't get involved. I think the best way to support, first of all, is to explain what it is you're going to encounter.
Mm-hmm.
Right? We're going to encounter things that no other field encounters. We are in the home for hours, doing very vulnerable activities, seeing families in their jammies, or right when they wake up, or maybe they missed the alarm and you're there and they're in their pajamas trying to get you in and trying to look like they've got it together.
Mm-hmm.
We see them when they're really emotional because their child has engaged in a challenging behavior that even we couldn't solve.
Right.
I think the best way is to level set with your team and saying, we are working with humans.
Yeah.
Like, in the end, we are human working with humans.
Yeah.
And, you know, when I work with the different teams that I have had the honor of working with, over the years, there's been numerous scenarios of these ethical dilemmas or ethical conversations of like, well, the ethics code says, I can't do this or this. I can't, you know, hug the mom when she's emotional because that's a multiple relationship. And one of my comments and feedback is, no, we can absolutely give mom a hug. If a mom is distressed, and I've walked into a home where a mom was absolutely distressed, if I stood back and just watched her cry, I would feel so inhumane, and I shouldn't be in the field.
Yeah.
Now, I will say, when I did hug this mom in this scenario, I did say, I don't know if this is in my ethics code, but I am so sorry for what you are going through, and is it okay if I give you a hug?
Yeah.
And she appreciated that, and she consented. And so I think that there's a level of just, we are humans working with humans, and we cannot remove our feelings for the families that we serve.
I love that.
That is huge, and I will definitely say that I have seen that and I've been there for that. There's just an added layer for me being a male. I'm like, I know that this is actually probably what you need at this point based on like your like behavioral signs that I am observing right now, like just to objectively define it.
Yeah.
I can see this, but I don't know if I'm the one that should be providing that at all, just because that is a big boundary that could potentially be there that can cause major problems.
You're right, and that's, you know, in those scenarios, I would even, because I've got a lot of male technicians I oversee, where even just a comment of, I'm so sorry, or nodding the head, and, you know, just making sure that you acknowledge the emotion, or do you need a moment, can I get you a napkin, is a nice way to neutralize it and then safely support.
Exactly, yeah. Those are the things that you pick up because you make the wrong decisions, and that reinforcement schedule wasn't there, so you would make adjustments moving forward.
And again, the black and white ethics code thing is like, man, I've made so many mistakes in these 20 years, 25 years at this point, where I have said the wrong thing, or I've, you know, made the wrong comment, or applied an intervention that wasn't effective, and then the child escalated, and I thought it would work. So I think that we have to be humble and, again, be human. Know our code, know our science, but also know that sometimes we're just trying to figure out how to effectively make change.
Yeah. And for that compassionate piece too, just to add onto that, I do feel like we can't get locked into our ideas, because it's like I had this idea and it didn't work, but it should work, so I'm going to do it again.
Yes.
Or I'm going to do it again. I'm going to keep trying until it does. That's not our science.
No.
That's what we try to undo.
Or people are in a very specific way, so they think that's the only way that will work. Yeah. Rough.
I mean, it can be. It absolutely can be. But to the compassionate care part, like that's what we're talking about. Like recognizing that we have those rigidities in ourselves, those biases, if you will, that we struggle with, because
maybe our culture plays a part in it.
100%.
Absolutely. But without reflection, we won't know. And like transparent reflection too. Whenever I talk about reflection, it's like, no, actually, you have a thought, you have your thoughts, you have your feelings, validate them, but just know where they're coming from and how they're affecting your behavior. So anyway, that was a little bit of a sidetrack, but
I like to call it checking myself, right? I just need to check myself sometimes.
Yeah.
Like if I'm going in with a specific mentality, mindset, or bias, why?
Yeah.
I need to check myself.
Yeah, and I feel like technicians, RBTs, BTs that are in, that is where they need help and support in knowing, like, it's a critical thinking component that comes with time, like time in the field, like,
experience.
Yeah, exactly. But we as BCBAs, we can't be like, we've gone through this, now they'll figure it out. Like, we got to find a better way to coach. It can't be like, oh, you'll get there. There is a way to coach this, and you're talking about it. Like, you're saying that these soft skills there's an ability to learn, open-ended questions, right? Listening with intent. The whole thing, you got 2 ears and 1 mouth, you're supposed to listen, like, I can't remember how it went, probably butchered it, but.
It sounds right. I don't know either.
I've never heard it.
Really?
It sounded like it was the right thing.
Yeah.
All
right, someone's gonna have to check me on that, because I'm pretty sure it's something along like you got 2 ears, so you're supposed to listen first, speak second, because 2 ears, 1 mouth.
That sounds right to me.
Sure.
We'll take it.
I think it's an
Right.
Australian thing.
It might be. I mean, who knows? It tends to. Isn't that just a thing? And it always ends up being an Aussie thing. So, so then, moving to kind of close up this episode a little bit for a BCBA listening right now who wants to show up more, be more present, what's some like concrete examples or things that they can do right now to be different, starting today or starting tomorrow, or in the next session as they're driving?
I'm always going to say, read the literature. I love the evidence. I love the evidence base. Taylor and colleagues paper, Rohr and colleagues paper. I would also reflect, engage in some of that self-assessment. There are a number of tools out there for us to evaluate our own skill sets. Check out the Jefferson Scale of Empathy. Are you empathetic? You can self-score. It's super easy. Read some of those papers, and then when you go into the home, connect with that family. I think it's hard when you think about the schedule of a BT, RBT, BCBA, clinic or home-based. It is back to back to back. I mean, we're at a point where we are automating session notes because we are so busy. So when you're back to back to back, sometimes that humanness gets removed. It's here I go to my kiddo that I've got for 2 hours that I see every Monday, Wednesday, and Friday, and now I've removed that connection because I've just got to collect my data points. Yes, the data is important. We have to track data. That is a requirement. But sometimes it's okay to set it aside for a second and pair. Build rapport, instructional control. Do it with the children, and then if you're in the home, do it with the family.
And you should be pairing often.
All the time.
Yeah, should never stop. It should never stop. I love the point too about like things are being automated now, because I will say I jumped on board so quick when there was AI systems that were HIPAA compliant that could do session notes. I didn't care about any other session other than my parent sessions, because I was like, I can be present and I don't have to type and miss half of everything that you're saying.
Yeah.
And parents, I had such like great responses when I asked parents, hey, are you comfortable with me using this so I can be with you? And they all said yes, and I'm like, thank you.
Yes.
And then I'm like, all right, like I'm here, and I feel like my sessions for parent consultation improved drastically. I did. Drama. Yep. You didn't even know. It's the day. Yeah, it was great. I'm like, wow, that's 2 times in 1 episode. I do know English, I promise. At least it's now and not on the panel in a room full of 100 people. That would have been fun. But it did improve the quality that I felt that I was giving as a behavior analyst.
And there is a reason for that, right? That AI can be leveraged in a way to support us in building that connection, being face-to-face with the family. And it's so embedded in what we're doing that I think parents are like, sure, my doctor does it, our dentist does it, I'll accept it, and you can look at me. I remember going into homes with my computer, and it felt so awkward listening, but like typing, and sometimes I would do a SharePoint note in, you know, a Word drive just so the parent could see that I am typing. I am not doing something else. I'm focused on you, but I'm typing it. And then a notebook felt silly because then I'd have to take my notes and then open my computer, and that's non-billable, and then type my notes there. So truly, that is where we can bring in compassionate care. I can now focus on you. I'm going to put this right here to record and automate, and let's have a conversation.
Yeah. Leveraging AI, not replacing.
Yeah.
Like leveraging it to help us, not to replace us. It's so important.
Well, thank you so much for this first part. And you guys tune in to catch us on part 2. And we'll see you soon. Bye.
Bye.